Our next topic is Vernal keratoconjunctivitis versus Blepharokeratoconjunctivitis, and the speaker is Dr. Hasanka Peiris. He is the acting consultant pediatric ophthalmologist at Teaching Hospital Karapitiya. Over to you, Hasanka.
Thank you for that kind introduction. So allergic eye disease and Blepharokeratoconjunctivitis comprise of probably the most significant proportion of ocular surface disease encountered in children. So I'll speak about allergic eye disease first. Allergic eye disease comprises of a spectrum of diseases which include acute allergic conjunctivitis, the seasonal variety, as well as the more chronic forms which include VKC and AKC. VKC is what I would like to elaborate more on. So it has a delayed hypersensitivity reaction as opposed to the seasonal varieties which have a, like a type 1 hypersensitivity reaction. So symptoms, the cardinal symptom is itching, and they would have redness and tearing. When the cornea is affected, you get blurring of vision, photophobia, and burning sensation. They have this characteristic stringy discharge in the morning, and it's really bad in the morning, so that's why they call it morning misery. So majority of these children even missed out on school days because of this. Locations to look for the signs would be the lids and the surrounding skin, the tarsus, limbus and conjunctiva, and cornea. So lids and surrounding skin in an acute, like a allergic episode, they can have some atopic edema. And in cases of AKC, atopic keratoconjunctivitis, like in the picture over there, they'd have eczema around the lids, and they have these folds just under the eyelids called Denny Morgan folds. So that's more or less characteristic of AKC. So when it comes to VKC, the most, the diagnostic thing or important thing for as far as diagnosis is concerned is papillae, and it has to be large papillae for that matter. So about a millimeter in size or more. So due to chronic inflammation, they can have varying degrees of scarring. So next you move on to the limbus. You can see inflammation around the cornea. This is known as Horner anthrus dots, which are inflammatory cells which have been accumulated. Cornea, if you stain, you can see superficial punctate keratopathy. In severe cases, you can see shield ulcers. Conjunctiva can be ingested. And also in children in this part of the world, you can see this antigen antibody deposition and pigmentary deposition in the conj quite often in these children. So assessment, there are various severity scales that are used. The Bonini scale is one that is used commonly. VKC, for that matter, you can classify it anatomically, whether it will be limbal, tarsal, or mixed. But basically, what you want to see is whether the child is progressing along and is the disease gradually becoming severe. So when it comes to treatment, allergen avoidance is main. So whenever possible, advise the children to avoid exposure to dust, wind, and also advocate the use of wearing sunglasses, hats, and goggles if they are going for swimming. And also advise them to wash their hands and face frequently. And general measures like cold compression really helps with the symptoms as well as congestion. So when it comes to pharmacological treatment, which these children may require in the long term, it's a stepwise escalation process that is required. Press free drops whenever possible, and can be used preemptively in case you're expecting episode to happen, like a seasonal change. So this is a basic flow chart of what we are using at the moment. So start off with dual acting agents, then move on to calcineurin inhibitors, as opposed to those days where we'd more readily go to steroids. use steroids, but as pulse therapy. And also, later on, you can use things like, oral antihistamines and maybe allergen-specific immunotherapy, and last but not least would be surgery. So dual-acting agents are the mainstay of, your first-line treatment. Dual-acting means that it has an antihistamine as well as a mast cell stabilizer quality. So olopatadine, ketotifen, epinestine, which can be dosed twice a day. So topical immunomodulators are also very important, and that is probably the second-line agent that you'd be using in children who are not responding to the dual-acting agents. So cyclosporin A is available at 0.05% here. So you can go for a twice a day to 4 times a day dosing, depending on the severity. So whenever possible, to use a cationic emulsion instead of a lipid-based one. Important to know that it has a delayed effect about 2 weeks. Main problem even with this and the tacrolimus is the stinging. So tacrolimus also is the other available drug to us. We use the dermatological ointment of 0.03. We don't have a ophthalmic-based ointment or the drop in Asia. In both cases, what helps is you can instill lubricant eye drops, artificial tears, 10 minutes before the installation of either tacrolimus or cyclosporin, and just make sure you depress the lower lid and place it into the inferior fornix. That will minimize at least the stinging, and you also have to advise the children and the parents that the stinging will gradually subside. Steroids are for pulse therapy, and also when, main indications are when the cornea is involved, when there's severe disease and limbitis. It's not generally recommended if only the conj is involved. So you use pulse therapy, use steroids which are more lipophilic like fluorometholone with low AC penetrance, and you reserve things like subtarsal steroids in case of very severe disease, like in the case of a shield ulcer. Systemic antihistamines are very helpful if the child is having rhinitis also, and also might dampen frequent episodes. In case of, when it comes to surgery, ulcer debridement is important for a case of a shield ulcer. Otherwise, when the plaque is there at the bottom of the ulcer, it doesn't heal that well. Excision of papillae, that's like a temporary measure, but it doesn't deal with the cause. AMG is useful for a very bad shield ulcer. So moving on to the next one, Blepharokeratoconjunctivitis. We don't see that much in children over here, but it has a totally different pathogenesis, and it can be kind of mixed up with VKC. So it's basically due to a staph, delayed hypersensitivity reaction to either staph or propionibacterium, and also because of the lipophilic material that's broken down from the meibomian glands, this can give rise to a delayed hypersensitivity reaction. So these children, the main issue is that they can be asymptomatic from the onset of the disease until they have severe corneal disease. So it's kind of important, rather than the symptoms, the examination is quite important. So they can have a bimodal peak, 5 to 7 years, the first peak, and the second one in adolescence, can be associated with some acne. Can be very asymmetrical, and when in severe cases, they can have photophobia and tearing. So you're looking at the lids, anterior and posterior. Anterior you can see crusting of the lashes. Posterior lid margin signs can be thickening of the lids, and also changes in the meibomian glands, like meibomian gland capping and pouting, like you can see. Lid margin telangiectasia, like you can see in this picture, and notching of the lid margin. So in more active disease, you are looking at a follicular reaction in the conjunctiva, and also flicton in the conjunctiva, which is basically inflammatory cells and an epithelial defect and a vascularization which occurs. In some cases, you can get subconjunctival crystals. These are quite pathognomonic, but it's not often seen. Corneal changes can be ranging from just a bit of SPK at the bottom, as opposed to diffuse corneal staining. And also this can progress to later on to sectoral vascularization and even a central corneal scar. So treatment would be lid hygiene, warm compress. So a modified lid hygiene is more applicable to children. Like, for example, you ask the parents to just get the cleanser or baby shampoo onto the fingers and rub the lashes while they're washing the child rather than the cotton bud. And you might need to use topical chloramphenicol, fusidic acid, maybe twice a day for about 3 to 4 months to get the things under control. Systemic antibiotics are very important in severe cases where the cornea is involved, and this involves either the use of erythromycin or azithromycin at moderate infection subtherapeutic levels, like about 50 to 80% of the dose. So, and these are given in the long term. So you give this until you achieve control, and then you try to taper off, and it comes back, and if it comes back, you go back to that least effective dose. So sometimes you might have the kids being on this for maybe about 125 milligrams on erythromycin weekly for maybe a long term, just to control this. Flaxseed oil is not available here. Flax seeds are available here. Flaxseed oil is also a very good option. You can give 2.5 ml per day. It also has an anti-inflammatory effect. It's good for your skin as well as the meibomian glands. Topical steroids are reserved for corneal disease. Again, same theory. You give soft steroids, taper off quickly, give lubricants, and also in both as well as BKC and VKC, you need to correct things like astigmatism, treat amblyopia, manage secondary infections, and in cases where the visual axis is opacified, you need to consider keratoplasty, address vascularization with either fine needle diathermy or bevacizumab. So that concludes my talk. Thank you very much.